garage type area where I kept my golf cart, and I'd smoke 3 or 4 cigarettes. And it was dark in there, had nothing to do but think. And I thought, if we keep using IMV and high levels of PEEP, we were hitting peak pressure sometimes of 80, 85 centimeters of water, which almost certainly was causing some damage to the lung. We had some evidence in patients that basically had an acute lung injury that we would anticipate would be taken care of in 24 to 48 hours, but with the high levels, we had created some injury, some pulmonary edema, and it took 2 or 3 days for that to resolve in patients. So it occurred to me at that time that we should begin thinking about ways of decreasing the peak pressure, but still having the ability to maintain an open lung concept, if necessary, with higher levels of PEEP. And that was right about the time when protective ventilatory strategies started to become popular in the late 1980s, actually, a little before I was worried about the high levels of pressure. A little after that, rather. And if you review the articles from American Journal of Respiratory Critical Care Medicine, internal, or in intensive care medicine from Europe, anesthesiology, I think you'll agree with me that the first protective ventilatory strategy that was emphasized was frequency. It was well known that at high frequencies, damage to the lung was more likely to occur than lower frequencies. And this is one of the first articles that I could find, although I know there were others earlier than this, that decreasing respiratory frequency can improve indices of lung damage. Another showed that if you used a peak inspiratory pressure of 50 centimeters of water, but a very low ventilator rate, there was little or no damage to the lung. And that's basically what we were doing with IMV in the 70s and the early 80s. But if you just increase that rate to 8 breaths a minute, the damage became quite evident. Another study showing the same thing with a peak pressure of 35 centimeters of water at a frequency of 3, little or no damage, about the same as it would be with 20, but increase the frequency to 20 with 35 at peak pressure, and you got damage to the lung. The next was hypercapnia. Efforts were made through the 70s and 80s to maintain normal capnia in most patients being ventilated. And then as patients developed hypercapnia that could not be treated with increasing rates of ventilation more and more, permissive hypercapnia came along. A rather arrogant term. It's like, I'm going to let the CO2 be high because there isn't anything I can do about it, as if we have control over it. But lo and behold, hypercapnia was shown to be, if anything, a protective strategy, making permissive hypercapnia more popular. Again, a couple more studies. And then inverse ratio ventilation. That's been around as long as I have in respiratory care. There were articles even in the late 60s, early 70s showing inverse ratio ventilation had a beneficial effect. And in fact, when APRV was first introduced, people just said, well, that's nothing more than inverse ratio ventilation. That's not true. You can't breathe spontaneously if you're on a ventilator set to give inverse ratio ventilation. And inverse ratio ventilation, especially with positive end expiratory pressure, was shown to be even more effective. Then a recruitment maneuver, and of course, recruitment maneuver followed by positive end expiratory pressure. And it wasn't really until 2001, 2002 that the low tidal volume ARDSNet group became pretty popular. And that became pretty much the standard of care for treating patients with so-called ARDS. It's interesting that in the original study, only 160 of 867 patients had a PF ratio less than 200 millimeters of mercury. If you work in a hospital where they do open heart surgery, very frequently a patient will come out on a mechanical ventilator on an FiO2 of 0.4, 40% inspired oxygen. Their PF ratio may be 200, and you know they don't have serious lung injury. It's different. It's different than ARDS. But ARDSnet is with us. It's still with us today. And as we heard yesterday, it's a very controversial topic. So from IMV to CPAP with APRV, I believe that was a natural evolution to protective ventilatory strategy and a very logical approach to avoiding lung injury. And basically, as I sat in that little garage with my golf cart, it occurred to me that if I could ventilate somebody this way with a level of PEEP at the baseline, why couldn't I just take away the CPAP momentarily and allow exhalation and then return? And that, to me, that's a very simple, complex, simple way of looking at mechanical ventilation. It can be complicated. You can try and compare this to other modes of ventilation, which of course has been done. If you don't understand the process, as was Dr. Daxon mentioned yesterday, you may have a very long T-low, if you will, so that the lung is allowed to collapse. But even at that time, in 1984, when I was thinking about this, it occurred to me you couldn't allow the pressure to stay low for very long or the lung will collapse. But if you do it for a very short period of time, especially the slow lung units, the ones that are likely to cause a problem, are not going to collapse in 1 or 2 seconds. So I went to Ohio State from there, teamed up with Christine Stock, who later, as she finished her fellowship, became the chair of Northwestern Anesthesia Department. And we published some of the first papers on APRV about 1985, 86, 87. Now, APRV is not BiPAP. Puritan Bennett licensed the patent I had on APRV. I got that in 1987. And they were going to call it BiPAP because they didn't think the respiratory community was quite ready for another 4-letter acronym, if you will. So they said, we're going to call it BiPAP. And I said, it's not BiPAP. BiPAP is something that Jerry McGinnis at Respironics invented for obstructive sleep apnea. It's totally different than APRV. BiPAP is not a ventilatory technique. Of course it is now, but it wasn't when Jerry first conceived of it. They said, no, we got to pick a term that people can understand. And then Respironics told them, well, you're not going to pick BiPAP because we already have that trademarked. So they called it bi-level. And they created a machine eventually. They kept the license for over 10 years before they did anything with it. And then they created a machine that was damn near impossible for me to set even. Rather than just having a rate setting and a T-low setting and a P-high and a P-low setting, they confused it. As those of you who work with the first ventilator that they had, the 840, I think it was very difficult to set APRV. A number of studies then came about. Putensen came from Austria to do a fellowship with me. He had worked with a German who actually developed a form of almost APRV. They called it BiPAP in Germany, and he spent 2 years with me. He and his wife did. And I want to emphasize this first animal study. It was published in '99. It was done about 4 years before that, and show a few advantages that don't get talked about too much when it comes to human ventilation. This was done in animals, but they repeated it when he went back to Austria, or to Germany rather, in humans. Now the airway pressure was maintained the same at about 20 centimeters of water with pressure support ventilation, pressure control ventilation, or APRV, to maintain the same mean airway pressure. Esophageal pressure that was measured with a fluid-filled catheter was the highest with pressure control ventilation, as you'd expect, and it was lowest with APRV. Those were statistically significant, meaning that the transpulmonary pressure, the inflation pressure, if you will, of the lung, was 50% higher with APRV than it was with pressure control, even with the same mean airway pressure. As you know now, if we use APRV, your mean airway pressure will probably be elevated higher than some form of controlled ventilation. Now with that, shunt that was actually calculated by using mixed venous values was significantly lower with APRV than it was with pressure control and pressure support ventilation, which, as I mentioned yesterday, I don't believe is spontaneous breathing. I apologize for the numbers being a little bit to the left for PO2, but you could see the PO2 is much higher. And I think very importantly, dead space was significantly lower with APRV. These numbers have been consistent with every study that I'm familiar with that have looked at APRV over the next 20 or so years. Now the numbers are really screwed up on this one, for which I apologize. But pulmonary vascular resistance, as we mentioned yesterday, was lower because we were closer to the optimal FRC. Cardiac index was a little bit higher. Ye God. Ron, would you shut my phone? Oh, I've got it here. Never mind. Sorry about that. Oxygen consumption. Chris Stock did a study when she was at Ohio State with me during her fellowship that showed if you let people breathe spontaneously, animals in this case, and measure oxygen consumption, and then paralyze them and remove carbon dioxide with veno-veno bypass, oxygen consumption was no different. So that spontaneous breathing in somebody that doesn't have damaged lungs or is at normal FRC, spontaneous breathing is not going to increase oxygen consumption significantly. And then the oxygen extraction ratio, basically the sum of the oxygen consumption divided by oxygen delivery, was, if anything, a little lower with APRV with spontaneous breathing than it was with controlled ventilation. Now, as I mentioned, pressure support is not the same thing. And then one of Putensen's fellows, Herman Riggi, showed in a study that spontaneous breathing actually improved aeration at dependent portions of the lung. I've not been involved with proning anybody because everybody I've ever ventilated has been breathing spontaneously for the most part. And I think with spontaneous breathing, proning is probably unnecessary most of the time. I won't say all the time, but probably most of the time. And then also with spontaneous breathing, of course, distribution of blood flow is optimal. Now, Varpula published this paper, which has been used extensively to say that there is no real advantage with APRV. Varpula looked at a number of patients with rather severe ARDS. The PF ratio was 150 millimeters of mercury or less. And then he compared treatment with SIMV and PEEP with APRV. His conclusion was that when used as a primary ventilatory mode in patients with ARDS, APRV did not differ from SIMV with pressure support in clinically relevant outcome. Now, I assumed that Varpula was an anti-ARDS or anti-APRV clinician for a long time until we had a meeting in Melbourne, Florida that was put together by Hibashi from the Maryland Shock Trauma Institute to gather a group of people from around the country and also from Britain and from South America that use APRV. And Varpula sat next to me. And it turns out that Varpula has used nothing but APRV for the last 20-some years. And this was his thesis for his docent's degree in Finland. And the thing that I want to emphasize is the survival that I mentioned yesterday that we had with IMV and high levels of PEEP was 80%, significantly higher than the ECMO trial that was going on at the same time. In Varpula, using SIMV or using APRV with rather severe ARDS had a much higher survival rate than has been reported with the ARDSNet, in this case, 83%. Now, probably the people who have done the most in terms of promoting APRV and have done the most investigation are Habashi and Gary Neiman. And they've collaborated now for probably close to 15 years or so and put on workshops throughout the United States. And I have a few slides that hopefully will work to show the differences with APRV. In this case, on the left, we have lung that's being inflated with a prolonged inspiratory time, with APRV, if you will. And on the right, microscopy with basically a microscope placed up against the surface of the lung. And you can see that the lung maintains continued inflation even out to 30 seconds of inspiratory time. So it's not unlikely that some level of CPAP will continue to recruit the lung for a long period of time. Now, that's the way Habashi uses the technique as well. And I do it slightly differently in that I will try and go to a higher level of PEEP. I don't know if the volume will go up or not. I hear some volume, but this is the lung being inflated, and you can see with time, alveoli will pop open. And if you look in the upper right-hand corner, even as we get out to 30 seconds or so, another alveolus will pop open. And this equates back, I think, to an observation that I mentioned yesterday when I treated Professor Carson in 1973, titrating PEEP up to higher levels than had been recommended previously. As I went up on the PEEP, suddenly his oxygenation improved. It was as if the lung had popped open. And this was an observation that Joe Savetta, Bob Kirby, and I made several times. And we saw it in almost all of our patients that received high-level PEEP. Now, this is one of Gary Neiman's slides showing, if you will, the ARDSNet ventilation strategy. Low levels of PEEP, collapsed lung, and the lung being basically ripped open, repeated alveolar collapse and expansion, or RACE. I think they are the ones that coined that term. And this would be the ARDSNet ventilation method. And you can see if you do this 25 or 30 times a minute, why it would be damaging to the lung. And now using video microscopy, the same thing. Sorry, this gets a little repetitious, I know. And this comparing the two, an inspiratory time of a second, if I can get it started, versus 5 seconds. Doesn't look like this one's going to play. Sorry. Think maybe I froze it. Is that possible? There we go. And this is reminiscent of a problem we had in the first human study that was done with Chris Stock at Ohio State University. IRB approval was a lot quicker in those days than it is now. We went to the IRB and said, we want to put this new mode of ventilation on patients after open heart surgery. So they came out from surgery and we put them on assist control ventilation and did some measurements. And then we put them on APRV. And the nurses were distraught because they didn't think the patients were being ventilated. They just saw the chest go down a little bit and come back up, down a little bit. So one of the problems we had is we had to keep repeating blood gases to convince them that they were actually being ventilated. And you can imagine if you had a chest wall, this is all you would see. These were patients, of course, with absolutely normal lungs. Their compliance was probably in the range of 70 milliliters per centimeter of water. We were ventilating them with 12/5 because we used a P low at that time. And at the end of the study, when they had been weaned by increasing T high, if you will, to infinity, so they were basically breathing with CPAP, we put them back on assist control to see if we could get another set of measurements. Every single patient said, quit it. I didn't sign up for that. They were very comfortable on APRV, basically with CPAP. They were not comfortable going back on assist control. And that led me to the rather strong opinion that there's no reason why you should save APRV for people with very significant lung injury. In my opinion, if a patient needs to be mechanically ventilated, they should be ventilated with APRV, 100%. I can't think of any patient that should go on assist control rather than APRV. So I'd be asked, well, what about patients with obstructive lung disease? Well, if you keep in mind that the time constant for the respiratory system is resistance times compliance, and a patient then that has very compliant lungs, COPD, with a high airways resistance, you're going to need a very long T low and a very low P high, if you will. Just enough perhaps to keep small airways open and long enough time, T low, in order to promote exhalation. Just another one, same thing. This is, I believe, a rabbit or a rat lung showing the same thing. Inflated lung with exhalation and back. And you can see why this would be a protective technique, if you will. So I'll finish with this, a quote from Grayson on how to debunk just about anything. And Neil McIntyre is an expert at this. He is just retired from Duke. He was the head of respiratory care there. He publishes quite a bit about APRV, although one of my mentees, if you will, is a surgical critical care attending there. And she said APRV is never used in that institution. The respiratory therapist will not allow it to be used. Even if the ventilator has the capability, they can't do it. So how Neil can publish about it, I don't know. But he does. And the first is to avoid examining the actual evidence. This allows you to say with impunity, I've absolutely seen no evidence to support such ridiculous claims. And note this technique has withstood the test of time, dates back at least to the age of Galileo, by simply refusing to look through his telescope. Ecclesiastical authorities bought the church over 3 centuries worth of denial free and clear. And then I'll finish with this that I mentioned yesterday. Harry Truman said, the only thing new is the history that we don't remember. So APRV is very similar to what Alvin Barrack did with a continuous flow face mask CPAP system, and Thomas Burford did. It's just that we now combine the ability to improve lung function in patients who have an oxygenation problem with CPAP, but also to allow them to be ventilated without increasing airway pressure. That was the goal in 1984. When I got the patent in 1987, I was pretty convinced that I was going to become wealthy with it. That didn't happen at all. The patent expired, I think, 5 years after Puritan Bennett finally decided to put it on their machine. So I did all right for a couple of years, but after that, of course, nothing happened. And now it's considered in many places to be a new technique, which I find phenomenal. It's approaching 50 years or 40 years since it was first published. And to think that something that's 40 years old and still considered new is impressive. Thank you very much. Thank you for the invitation to come. It's been the highlight of my year. I'm sure it'll be the highlight of the decade for me. And I greatly appreciate the invitation. Getting to see some old friends and also to people who I've crossed paths with decades ago in some cases. Thanks again.
Thank you so much, Dr. Nanda.
Thank you.
Great. We're really happy that you're here.
Thank you.
And I see some questions if you don't mind.
All right.
I'm just curious, your opinion on, as far as I noticed on the videos, there were a lot of small animal lungs used. What's your opinion on using this across the whole age spectrum, using it in pediatrics with any restricted lung diseases, using APRV? And then the one thing that I do see a lot is the people that are afraid to use it in those age populations. What's your experience with pediatric populations?
Well, my experience with pediatric populations is zero, because I haven't ventilated a pediatric patient outside the OR in probably 40 years. When I was in Champaign-Urbana, Illinois, in private practice, when the neonatologist would go on vacation, he told the nurses Downs is going to cover for me. And so I did cover a neonatal unit then, but that was before we were using APRV. We were still using the baby bird then. The first positive studies that came out on APRV were actually done, I believe, at Johns Hopkins in pediatric population. And then whoever was doing the studies quit. I don't know if they probably left, went someplace else, and that was the end of it. But I would think that just as the continuous flow, intermittent ventilation with a baby bird was beneficial, I would think keeping a constant positive pressure and making sure that lung didn't collapse on release would be very beneficial in the pediatric population. And I don't know why there would be a fear of using it. The chest wall is so compliant in the neonate, they would be using low levels of pressure. I don't think the airway's resistance is high, so they probably could get by with short release times and very low pressures and still have beneficial effects. But I have absolutely no experience, so it's with drowning patients. Again, I don't have any experience in drowning, although I came from Gainesville, where all the near drowning studies were initially done. But that would be the ideal patient population, I would think, because they did very well with IMV and the higher levels of PEEP. We had a number of patients that were near drowning victims, and they recovered very quickly, interestingly. The lung heals very fast if you keep it open. We had a few patients who died of sepsis when I was in the Air Force. We infused formaldehyde through the pulmonary artery catheter and then put it down the airway after they died with permission of the family. And we basically embalmed the lungs in situ. And we got slides of those, and the slides were remarkable. The alveolar type 2 cells almost looked cancerous. They were so prevalent. The lungs were healing in those patients, in some cases only 6-7 days after the initial insult. So I really believe if you keep the lung open, it will heal. And that's why this so-called resting the lung on ECMO and so on doesn't make much sense to me. I don't think the lung recovers very well when you allow it to stay collapsed for long periods of time. Sorry, I couldn't answer the question more authoritatively. Yes, sir.
Two questions. First, spontaneous breathing has obviously a lot of benefits. There's also a lot of debate about e-cili and injurious effects of spontaneous breathing. It sounded like you would almost universally have the patient spontaneously breathing. Are there times where you electively would not let them breathe at a certain PF ratio or anything else? And the second question is maybe the most important question. How do you convince surgeons that you're sharing a patient with in the ICU that it's okay to use APR? And they hate it.
It's a lot easier now than it used to be. I mean, I think anesthesiologists are running cardiothoracic intensive care units now, and they used to be the hardest people to deal with. When I was in the Air Force, I was dealing with a Duke-trained cardiac surgeon who would never leave the ICU. And after about 3 months, he said, "You're the only anesthesiologist that I've ever worked with that's here more than I am." And that basically was how I convinced him. And we later became such good friends, he was recruited to the University of Florida. And my anesthesia colleagues never forgave me for that because he didn't have the same view of them as he did of me. I think probably I'd take the same approach I did with IMV in the beginning and do it at night when they're not around or when they're in the operating room, and then convince them with positive results. And I would absolutely not use it on somebody who's almost dead anyway, that's been on a ventilator with 100% oxygen for 3 weeks. That's not the patient to first try it on. Somebody with basically normal lungs that can do well with any technique, if you could show them, look, I can ventilate with this. And that's what we've been doing at Moffitt Cancer Hospital in Tampa. We convinced a thoracic surgeon that we could use APRV basically in the OR with room air during 1 lung ventilation. And the results were so positive that that's all he wants used now. And this was a guy who also was Duke trained many, many years ago, did the decade with Dave, and was very hard to convince of any kind of change. As far as whether or not I would allow patients, I would keep them from spontaneous breathing. I can't think of any. Our goal when I was in the Air Force and using the higher levels of PEEP was to get them to breathe, even if they weren't moving any air, just if they were making respiratory efforts and dropping pleural pressure, some cases 5 to 10 centimeters of water, but their lungs were stiff enough that they weren't moving any kind of tidal volume. But that was still enough to maintain venous return. And I really can't think of any. Perhaps some forms of COPD where gas trapping gets worse, but I would probably reason that I have not sent the ventilator correctly in terms of the PEEP levels or whatever, if they're having trouble with gas trapping. Did I respond to all of them? Okay.
Thank you.
Thank you.